We have to say that the way to one's heart is through his stomach. I'm sure Kedila will be taking us to their hearts by giving a sumptuous dinner, and I'm not going to stand between you and dinner for too long. So it'll just be about 15 minutes or 20 minutes on this brief. What I'm going to cover in this talk is on GERD and non-cardiac chest pain, GERD and atrial fibrillation, then chronic GI infections and how they can affect the heart, the IBD, the inflammatory bowel disease and the heart, the cirrhotic cardiomyopathy, and then the heart failure and gut microbes, how they can play a role. So one of the commonest problems that one encounters in the clinic is a chest pain. So you do an ECG, you do a trope I or trope T, when it's negative, then you just relax, saying this is something to do with your GI system. So one of the commonest things that we encounter is a non-cardiac chest pain. If you take 100 cases who come with chest pain, not every time it's going to be cardiac. But nevertheless, the weightage should be given to rule out a cardiac problem like a heart attack, because that will be life-threatening, whereas the GI can come a little later on. So the non-cardiac chest pain mimics angina pectoris. It's worse after meals and comes up after emotional stress and awakens from sleep also at times. And the mechanisms are multifactorial. It can be related to the acid surge into the esophagus, the hydrogen ion, the concentration, the volume and the duration of acid reflux. And also it can, when the acid reflux happens, the esophagus can go into spasm. Even otherwise esophageal muscular spasms do happen. So it could be also secondary esophageal spasm or prolonged contractions of the longitudinal muscles of the esophagus. So basically the esophagus goes into spasm, producing a pain which is a non-cardiac chest pain. So we can just do a manometry which can show the non-cardiac chest pain, because the muscle contractions of the esophagus can be measured. And now we have the Chicago classification, which can give all the parameters to call it a jackhammer esophagus. Previously we used to call it nutcracker, now it's called jackhammer. So we can easily measure off the pressures in the esophagus using the manometry. GERD and atrial fibrillation have an overlap. How many of us realize this? If you see, one of the commonest problems of GI disorders that we encounter in the clinic is the GERD. Again, atrial fibrillation is the most common clinically significant arrhythmia among the general population. But what is the correlation between the two? And it was Kunz who found that GERD increases the risk rate of atrial fibrillation by 40%. The actual reported incidence of patients with GERD and atrial fibrillation is only 5%, which means it's the tip of the iceberg that we are seeing, recognizing, but many of them go unrecognized, because what happens is even the reflux episodes are unrecognized, and so the atrial fibrillation also goes unrecognized. It automatically stops in many patients. And there's a beautiful article in the World Journal of Gastroenterology published in 2014, which spoke about atrial fibrillation in patients with GERD, a comprehensive review. What the authors did was to go through 2,161 titles from different databases, and they found that 8 articles met the inclusion criteria for a combination of atrial fibrillation and GERD. And what they found was the atrial fibrillation in patients with GERD was anywhere between 0.62 to 14%. It is higher when compared to those without GERD. The mechanisms of AF as a consequence of GERD remain unknown, but many hypotheses are there. I'll show in the next slide. And then the treatment with PPIs may improve the symptoms related to atrial fibrillation and also facilitate the conversion to sinus rhythm. So the GERD can lead to AF, and this could be because of inflammation, autoimmunity, or exacerbated autonomic stimulation. So the GERD can produce a vagal stimulation, which can depress the sinus node depolarization and also the atrioventricular AV node conduction. It can also produce a local atrial inflammation because of the contiguity, and also through the inflammatory mediators IL-1B, interleukin 6 and CRP. Autoimmune response because of autoantibodies, anti-myosin heavy chain antibodies have been detected. Decrease the coronary blood flow has been detected in GERD, which can produce a chronic atrial ischemia, and hiatus hernia can have a mechanical effect on the left atrium, also causing inflammation of esophagus. And genetic has not been evaluated, though this article says. In 2009 in the Minnesota County in the United States, beautifully done studies show that the GERD can be genetically transmitted down the generations. So 5 generations it can be transmitted through genes, sometimes even skipping generations. So GERD can be a genetic disorder. If you go back and ask your patients of GERD, did your dad or mom or granddad or grandmom suffer from this disease? And the answer in the majority of the situation will be yes. So AGA guidelines for the GERD management. The first thing is the lifestyle modification. Of course, H2 blockers do not play a role. So we have to go with the proton pump inhibitors, and I was the first one in India to combine a PPI with the prokinetic. So I was previously in 1990s, the Janssen CLAC came with the first cisapride, which is a prokinetic agent, after domperidone and metoclopramide came in. So that was the time, I started combining, because that was the time GERD became also more recognized. In the early 80s, we never recognized GERD in our patient population that much. It was there, but we never realized that the gastroesophageal reflux was so important. So it was in the early 90s that when I recognized that GERD could be a problem. And in gastroesophageal reflux disease, it is not a disease of hyperacidity. It is a disorder of motility. So where the emptying of the esophagus is defective and there is sensitization of the esophageal epithelial cells, the lower esophageal sphincter is lax, and there is a duodenogastro-esophageal reflux, which could be alkaline, and also delayed gastric emptying. So it's a motility disorder with a normal acid pH in the majority of the situations. So the acid comes up and stays in the esophagus for long duration, producing problems. I'll show you one beautiful case to follow, how acid reflux can produce so much of damage in the esophagus. So this acid reflux can be taken care by prokinetics. Again, you'll all agree that the spiciest cuisine is the Indian cuisine, only next to the Chinese. And if you take the Western, foods, they are bland. And so those guys can do well with just double dose PPIs, but not the Indian counterparts. So we have a lot of spices and condiments and fats and fried foods, which can all produce reflux because of the lowering of the esophageal sphincter. So the prokinetic combination is a winning combo. Today I'm so happy I was the first guy to make an Indian company combine a prokinetic with the PPI. And today, like all prescriptions go with a combination, because the reflux disease is much more common than peptic ulcer disease, which is just fading away. It's much, much less. So you combine a PPI with the prokinetic, or you can do an anti-reflux surgery in patients who continue to be symptomatic. So one of the devices which came and went and again came back was a radiofrequency ablation device, the RFA, the RN system, the BAC system. So which was introduced in 1998 in the World Congress of Gastroenterology in Vienna. I saw for the first time, but never took off. But right now it has made a comeback in the US. It's about 3 years. What they do is they just burn the distal end of esophagus, and which are electrodes which can poke into the musculature. So they burn the muscle and then produce a fibrosis, and then there is a stricture that happens in the distal end of esophagus, which just prevents reflux. That is the basic concept of radiofrequency ablation, but it's not yet introduced in India that widely, and it's probably not the best methodology. And in 2012, the FDA approved the LINX device. So here, what happens is there is a small expandable ring of linked magnetic beads. So just what is seen in the hand of the person holding is a ring magnetic beads. And we have surgeons here. What they can do is they can go and fix it at the junction, the lower esophageal junction. So when somebody swallows food, it opens because the magnets will move apart because of the food bolus pressure. And if something tries to come up, it does not allow. So it's a simple device. It's available in the US, but still not been marketed into India. So there are other methods which I'm going to show you some interesting video on this anti-reflux mucosectomy, the ARMS procedure, which was described by Inouye in Japan about 9 years back. So he did not release it to the world until he did a thorough follow-up, and then after 9 years of follow-up, he just released his invention. And so we have started using it. Even at Coimbatore, we do the anti-reflux mucosectomy, which can be done in patients with the lax esophageal sphincter and reflux and not hiatus hernia. If there is a hiatus, then we have to depend upon the surgeon to do the laparoscopic fundoplication. And the Gerdex is a disposable device which can put clips, like the T-tags in the OG junction on a reverse basis, on a chain maneuver. And only 2 procedures have been done in India. One was done in Hyderabad, the other one was done in our unit, the Gerdex. It's imported from Germany, it's fully disposable. The problem is the cost, 4.5 lakhs for one disposable device and one procedure. So how many Indians can afford? I cannot understand. So I'm just giving you a case of Mr. K, who had a reflux symptom of 5 years not responding to medical treatment. In 2014, we spotted Barrett's esophagus and we did a radiofrequency ablation using Halo 90 system, but the patient continues to have symptoms. So this is what we found in endoscopy. He's got grade C reflux esophagitis according to the Los Angeles classification. Also the distal end had a Barrett's dysplasia, early dysplasia. So we had to ablate that segment. Then the manometry, the black and red are high pressure, the blue and green are low pressure. If you see, the top portion is the upper esophageal sphincter, which is closed, and the lower portion is the lower esophageal sphincter, which also has to have at least a red yellow, but it's green, which means it's very lax. And also the motility of the esophagus itself is disordered. So this is a gentleman had a hypertensive LES and a disordered peristalsis of esophagus. So these sort of cases, if you do a Nissen fundoplication, a 360-degree wrap, then the patients may not be able to swallow well. So if somebody is going to do a Nissen wrap, I think we have to do esophageal manometry before attempting to do a complete 360-degree wrap. So these sort of disordered motility people should have a 240 or some other partial wraps. This patient off PPI for 1 week, we just put them through impedance pH manometry. So impedance pH metric. So just the pH alone will not help because it does not detect all the reflux episodes. So impedance pH has to be the way to go in order to detect the reflux. And you see here what comes below the dotted line, which is the pH 4. So if it comes, whatever comes down is the reflux. So the first probe is the acid probe of the esophagus, which is placed 5 cm above the LES, and you can see significant acid reflux that happens. Also, patient has some volume reflux also. So if you see here, the patient had the longest episode of reflux, which went on for was 1 hour when the patient was upright. When the patient was lying down, it was beyond 3 hours acid was staying inside this esophagus. That is why the esophagus showed so much of damage. So these patients, they develop a lot of complications, right? From carcinoma of esophagus, which is adenocarcinoma, the Barrett's, to carcinoma of laryngopharynx, and also strictures in esophagus, and all sorts of complications can happen in these people. So the Demeester is a gastroenterologist in the US who gave the score, which is called the composite score. Here in this gentleman, it is 85. It has to be 14.7. It just calculates how much of acid is coming up and how long is it staying in the esophagus. So this is very useful when you're doing an impedance pH study in order to know how much acid is coming up and how long is it staying in the esophagus. This one had a score of 85, very high. It has to be below 14.6. So this is what we did. So this is the procedure which was described by Inouye, which is an endomucosal resection. So this is called anti-reflux mucosectomy. So first we mark the points in the lesser curvature of the fundus where 2 centimeters is left behind, because the RF ablation device will produce circumferential fibrosis and can produce strictures. But whereas this one will not produce that. So because we are leaving 2 centimeters on the greater curvature side, and then we do an endomucosal resection. This was what Inouye did when there was an adenoma of the fundus of his patient in Japan. So he did the mucosectomy to remove the adenoma, and later on the patient who had reflux came back without any reflux symptoms. He was absolutely off PPIs, and that is how he started this procedure, followed up for 9 years before he released this innovation. And then I started it a year and a half back. So, and then I also first waited. This is the first case that I did after taking his consent, because he did not want surgery, because we do it endoscopically through the mouth. So we just did this procedure. So only thing is bleeding can happen in this site. And this was the Hemoseal spray, which is the collagen spray. And I was the first person in the world to use collagen spray through endoscopy for the bleeding lesions and also for ulcers, which it forms a physiologic barrier to acid and pepsin, and also it forms a matrix over which the cells can grow from the border of the abraded mucosa and can quickly start growing in. So the collagen comes into play on day 5 or day 7 after injury, whereas here we're just using collagen at hour 0 so that the healing process gets enhanced. So even after such a big resection, 6 hours, patient is able to tolerate hot liquids and hot foods. So the patient can easily get discharged. These are all the steps of the ARMS procedure, which is anti-reflux mucosectomy, and this is after collagen. And you see here the result. Before the surgery, he had such a lax ileus. So, but after this, ARMS procedure, it's absolutely looking like a great wrap. And the patient, believe me, is on follow-up for 1 year now, and is absolutely off PPIs, off prokinetics, absolutely doing well. He also had, Barrett's dysplasia, early dysplasia. So, and look at the impedance before the ARMS procedure, and this is later. So the score has come to 12.1 from what was 85. So this is the only case that I did and watched and followed up for 1 year, and then I found it so useful that now I'm doing it for even the post fundoplication failures also. After 5 years, if the wrap becomes loose, then we can do it from inside. What the surgeons, it will be a nightmare for the surgeons to undo the wrap and do a wrap again. It's probably messy, but we can do it very safely for these patients through the mouth. So GERD and atrial fibrillation, to correlate, there is a higher incidence of atrial fibrillation in GERD, but unfortunately, if you treat GERD, can you prevent AF? We don't have any data on that. And chronic infections, that is the next area that I would move to, and coronary artery disease. One of the important causes of inflammation in this whole system is Helicobacter pylori. So in fact, when I was addressing the API, South India API in Bangalore about 15 years back, and one of the cardiologists stood up and asked, so Dr. Prasad, we have recognized H. pylori in the coronary blood. So what is H. pylori doing there? So, and I was a speaker. So I said, I'm really sorry sir, maybe sightseeing, because it went to the wrong area and doing some sightseeing somewhere. So we didn't know, we had no answer to that question. But now we know that H. pylori induced inflammation itself is enough. It need not go and travel to the coronary circulation. Sitting in the stomach, creating inflammation can produce all complications of coronary artery disease. So this is one of the commonest problems in India. So 40% of all our dyspepsia patients have H. pylori, and atherosclerosis has been correlated and correlated with H. pylori infection. So CAG-A positive, which is a virulent strains, are more involved in coronary artery disease, and the mechanisms of H. pylori related atherosclerosis is chronic inflammation, endothelial dysfunction, increase in platelet aggregation, and hyperhomocystinemia and dyslipidemia. All these have been invoked here, and numerous reports have found the role of H. pylori in the causation of coronary artery disease. This was a study where 120 patients underwent coronary angiography. H. pylori infection is more in patients with angiographically documented CAD, that is more than 50% stenosis at least in one coronary artery, 70% with single vessel disease, 76.3% with double vessel disease, and only less than 50% in no coronary artery disease. And again, a large study from South Korea evaluating 2029 individuals for H. pylori antibody and coronary artery calcification found a link because the H. pylori seropositivity was different among those with or without coronary artery calcification. So atherosclerosis is a multifactorial disease secondary to chronic inflammatory process, and acute coronary syndrome is again because of plaque instability and the thrombus formation as a late event, and it is all this has been found to be more in H. pylori positive guys. Lot of publications have happened in this area implicating coronary artery disease and H. pylori infection. So today, not today, right from 1990s, I used to get the flow test from Delta West Australia, and I used to check for H. pylori in every endoscopy that I did and cleared the H. pylori. I've had discussions with the latest topics, and professor from Italy was there with me, and again Professor Guido from Japan. All of them vouch by that if you do an endoscopy, please look for H. pylori and eradicate it. The Japanese government does serology, free serology for H. pylori detection for all Japanese people, and they eradicate once it's found positive. So that is the extent to which the Japanese government has done on H. pylori eradication in Japan. So it's completely free. So all guys will get H. pylori detection free and treatment free if they are found positive in Japan. So because WHO has called it the class 1 carcinogen. So right from 1990, I've been looking for the H. pylori. So now we homebrew our solution from 1992 onwards. Previously we used to import the flow test from Australia. So ACG guidelines on treatment of H. pylori, I'm skipping through. Generally people use a triple therapy for 2 weeks. I use a bismuth quadruple for 1 week, which came from Guido Tidgert's unit from Amsterdam, where I went on training. So I just thought it's very good that 1 week you can do away with the H. pylori. So again, one more area which can lead to atherosclerosis is hepatitis C virus. So hepatitis C virus related inflammation can also lead to atherosclerosis. So just skipping through for want of time. So lot of studies. This one had 89,000 HCV infected subjects in United States. It was a 5-year study, and the data showed an increased risk of cardiac diseases like myocardial infarction, congestive cardiac failure, coronary artery bypass, grafting, or angioplasty. In spite of being young and having a more favorable cardiometabolic risk profile, still they got it if they had HCV. So HCV patients are also at a high risk for developing coronary events. Again, what I'm not going to show here is the non-alcoholic fatty liver disease, the NASH. The NASH coronary artery syndrome and the coronary events have been beautifully described by so many studies. So if there is somebody with a non-alcoholic fatty liver disease, you should try to stop the inflammation in the liver. Then the coronary risk also comes down. That's been beautifully demonstrated. So now we have, thanks to the direct acting antivirals, sofosbuvir, ledipasvir, sofosbuvir, daclofasvir, or sofosbuvir, velpatasvir combination, we have 98 to 99% clearance. And this last week we had our paper presented in American Association for the Study of Liver in the US, and this was a real-time of 4 of us joined together and published data of 1,200 patients of hepatitis C treated with DAAs. We could achieve 98% success rate, which means SVR rates of 98%, which means not the end therapy. 12 weeks or 24 weeks after eradication, the C virus is not there, which means It is a complete cure. So this, I'm sure, will happen even in hepatitis B, because there are 3 new drugs which are in the pipeline. By 2022, we can really boast that we will be able to completely eradicate the B virus also. Now, the very short-term treatment with 100 milligrams of glecaprevir and 40 milligrams of pibrentasvir has been approved in the United States from August 2017. You need not even treat for 12 weeks or 24 weeks. Just with 4 to 6 weeks, you should be able to eradicate C. That is the way we are going towards C. The lesser the duration and with the higher success rate. Chronic infections like H. pylori, HCV can increase the cardiovascular disease, as I showed you earlier. Last few slides on inflammatory bowel disease, the ulcerative colitis and Crohn's disease. People have found that IBD increases the risk of coronary artery disease. IBD flares have been associated with VTE events. So very, very important. And the treatment of the inflammatory bowel disease is the like from the bottom of the pyramid. You start with 5-ASA, go on to prednisolone or budesonide, then go for azathioprine, methotrexate, and then you go for biologics and finally surgery. Today the US is looking at a top-down approach. They start with biologics because here the white cell mediated attack on the mucosa is the one that is causing the inflammatory bowel disease. And I understand 2 days back there was a publication in Hindu which demonstrated orally they showed Klebsiella positivity in guys with inflammatory bowel disease. Probably that could be the missing link. Like in irritable bowel syndrome, the Campylobacter jejuni cytolethal distending toxin B, CDT-B, has been found to be very similar to vinculin, which is a part of the interstitial cells of Cajal in the neural transmission pathway in the musculature of the gut. And because our antibodies go and attack the CDT, cytolethal distending toxin of Campylobacter jejuni, these antibodies go and attack the vinculin in the ICC, the interstitial cells of Cajal. That leads to post-infectious irritable bowel syndrome. I'm sure we will come out very quickly with some hypothesis to show Klebsiella linked to inflammatory bowel disease. This is something new and just 2 days old. So, but I need to go in more into the detail on that. But inflammatory bowel disease definitely increases the risk of coronary artery disease, because wherever there is an inflammation, there are more cytokines going in the system, and they can produce endothelial, vascular endothelial damage where atherosclerotic plaques develop. From there, people can develop chronic, ischemic heart disease, or the plaques discharging can produce an acute coronary syndrome. And finally, the cirrhotic cardiomyopathy is a very recognized entity. So previously we thought the alcoholics having cardiomyopathy was only because of alcoholic cardiomyopathy, not necessarily. Even the non-alcoholics, cirrhotics, can have cardiomyopathy, and they all have problems with the reduced left ventricular ejection fraction and left ventricular diastolic dysfunction, all have been found, and prolonged QT interval have been found, and hepatorenal syndrome also has been increased in patients with cirrhotic cardiomyopathy. So there is no specific treatment for a cirrhotic cardiomyopathy, but the best thing to do is to do a liver transplantation that completely cures the problem. So gut bacteria can influence the heart health. So because patients with heart failure have a disorder of gut epithelial dysfunction, so where there is a microbial dysbiosis, and these bacteria, see what happens is, if there is a heart failure, there is a venous congestion, and also portal venous congestion can be there if there is a stasis in the liver, and the tight junctions of the epithelial barrier of the intestine becomes loose, and so the bacterial antigens can be taken up into the submucosa where it is exposed to our inflammatory cells. So the antigen precursor cells and the T cells and the B cells, which triggers on chronic inflammation. So the heart failure can also produce a dysbiosis, can also produce lot of problems by way of gut microbiota. So people have shown that a 3-month probiotic therapy with Saccharomyces boulardii for 7 chronic heart failure patients, they've shown an improvement in the left ventricular ejection fraction from 39 to 45 and a significant decrease in the left atrial diameter from 4.49 to 4.20. So the total cholesterol, uric acid, HSCRP, LVAF, all this come down, LVAF improves, left atrial diameter comes down. All this has been shown. So I think this is the last slide that I wanted to take you to a new arena which is unexplored. So people do not understand the GI cardiac link can be there in many diseases. So this is just an eye opener for you. So when next time you see a patient, heart patient in your clinic, or a GI patient or a liver patient in your clinic, also you should look for cardiac problems because they can also coexist. So there is a correlation between GERD and atrial fibrillation, chronic GI infections and coronary artery disease, inflammatory bowel disease and coronary artery disease, cirrhosis and cardiomyopathy, and heart function and the gut microbes. There are higher incidences of cardiovascular complications in patients with GERD, chronic GI infections, IBD, cirrhosis, disturbed GI flora. There are clinical data to support that active management of these GI disorders would reduce cardiovascular events and complications. I thank one and all of you for this very patient listening. Thank Devida for giving me this opportunity.